Good morning everybody. My name is Dr. Apurv Mehra and I am an orthopedic surgeon. This video talks about knee replacement with a robot. The name robotic TKR is catching the eyes of everybody in the world, both the surgeons and the patients. In my practice, I never saw patients so demanding that will you be operating through a robot, with a robot, without a robot. So let me start with the first point. Point number one, it is never robotic total knee replacement, right? Unlike laparoscopy, where the laparoscopic surgeons are outside the field, the robot is inside on the patient and they are controlling from outside. In total knee replacement, it is robot-assisted total knee replacement. So robot is on the side of the OT table and the surgeon works along with the robot. What in a total knee replacement the robot will do, what it will not do. So the steps, will it open the knee for you? Answer is no. Will it expose and remove the soft tissues from the planes? Answer is no. So the surgeon is taking care of the soft tissues, which is extremely important for the success of a knee replacement. What does the robot do then? Robot will make the cuts in your thigh bone called as femur, make the cuts in your leg bone called as tibia, will not cut the third bone in the knee called as the patella. Total knee replacement, fondly called as TKR, is the #1 done surgery in the world nowadays and claims as 99.9% success. Already before the robot entered. What is it doing? It is increasing the precision. How? It is making better femur cuts. It is making better tibial cuts. And according to me, the cut of the tibia decides the future of the knee replacement. It will, after this, get away. Now comes an important part. Surgeon will do the cementation. Surgeon will put the implants. Surgeon will further check and surgeon will do the closure. So the anxiety that my patients have, will the surgeon be not involved in it, is not true. The surgeon will use his experience throughout. Exposure, closure, implantation is surgeon exclusive. Cuts is robot assisted. So this is what is robot assisted total knee replacement. So what is this? This is a robot which is going to help you in doing a total knee replacement, right? What are the different components of a robotic knee replacement? You have this setup by which you will do a calibration. Then it will have an arm which will make the cuts on the bones, right? If you look at the opposite side, you have the arrays which will coordinate with the arm there, right, at the top, so that it aligns and helps you progress in the surgery. So हम लोग एक तरफ bones के कट लेंगे और वहाँ पर हमारे को पता लगेगा कि हम किस किस तरीके से cuts को ले रहे हैं, उससे क्या difference create हो रहा है in the knee. So when we take the cuts, the robot, whose base is the computer navigation, will help us know whether the cuts are adequate and the balance is adequate. So let's start with the calibration. So since you must know that I am a surgeon who will do the femur first or the thigh bone first. So there are different options here. You can do a femur first, you can do a tibia first, or you can do a hybrid. There are different ways to combine. So let me do with total knee femur first. So when I go with femur first, the robot starts loading the system in which I have. So now the next screen has come. It is initializing and it is checking whether all the wires are in place, the connection is adequate or not. So this is for the basic connection being adequate or not. Normally when a surgeon comes, before that this calibration is already done by the team. It is basically activating the robot in the other word. If you see that this is a Wellis system. Wellis is made by Depew, Johnson & Johnson made in USA, and it is very interesting to know that the robot works with the specific implant. So if I am doing a Johnson Depew robot system, it means automatically I am going to put the implant of Depew Johnson & Johnson. The Velis system is compatible with one of the finest knees the world has seen, the attuned knee, right? A tuned knee is tuned to the human knee the closest. All right, so this is number one thing. Now it says that select a surgeon account. So I will like to go with my own name, and we will enter a particular password to log into the system. So as we enter the system, now we have got the patient information. Why is the patient information very important? Because you will be able to put up what exactly you did, and this is the data that you will create for your registries. So it is very important that you put the correct names here. For the demonstration person, we move to not specified. We are doing the left knee replacement because that's how the setup has been done on the table. So we will do the left knee replacement. So we have chosen the left knee replacement. So now we have the cautery pads. If you remember the blue and the yellow cautery pads that you have, the cautery push buttons you have when you're using during the surgery. All right. So those are there. We do it during arthroscopy when we are using the probe. So we have a system there. So we will press the blue button and this will start calibrating for the knee. So it is looking at the motion into a different axis. The robot arm is trying to see whether it's free to move in all the axes to make the adequate cuts. Now the robot is mounted and we are towards the last step of calibration. So this is called as the handshake, and here the surgeon is getting accustomed, right, with the saw and the robot for the cuts. So now our calibration is done and we are ready for the robotic knee replacement. For those who are wondering what am I doing with this pin in a case of knee replacement, remember that we learnt during our first year residency how to put an external fixator, and look at how the clock has ticked. We have come back to the basics for the knee replacement. We have to put 2 pins on the upper end of tibia and 2 at the lower end of femur so that we can fix our devices to align with the robot so that the cuts are more precise. So the first pin, right, will be at the upper end of tibia, which will be at a 45-degree angle, right, and we will be drilling it inside. Now we need another pin. So to align the array, we need to put 2 pins. So we are putting the second pin here, just like we used to do the universal clamps, and here we are done, right. The similar thing will be done for the femur now. The rule is the same. We are going towards the lower end of femur, and our aim is to apply the pins so that the array will face the cameras. Our aim here is to place the array in align with the cameras. So it's along the shaft of femur. So now these arrays will be pointing the camera so that we can do the knee replacement with, which is robot assisted. We have fixed the arrays in place, and if on the screen you see green, it means they are in the correct position. The arrays are in the correct position. This is the point on the upper end of tibia, which is about a centimeter from the joint line, right, which we will use as a reference point for the array on tibia. So we will mark this, and then we will do it on the lower end of femur. The similar thing, we will mark this. So these points are going to be fixed. They have to be marked so that they don't keep changing. Now we are going to do something which we used to do in the navigation also. So we are going to find the centers of different area. So we will do the hip rotations. Do it firm so that your movements are transmitted right to the hip. we have first collected the hip center, then went on to the ankle. Now we are on the upper end of tibia, the intercondylar area. So we are at the intercondylar area for tibia, going to the medial tibial plateau, the lateral tibial plateau, the intercondylar line, the notch, the medial femoral condyle, the lateral femoral condyle, so we are on the posterior femoral condyle, the lateral side. So if you look at the lateral cortex of the femur, where you make a cut when you make an anterior cut, so you are trying to mark the same. So this is if you are verifying your cuts. If it turns green, means this is what you wanted to do. Now we have verified the points and we are ready with almost the cuts that are to be made, and we want to assess what will happen if in this position we make all the cuts, right? So then, since this is a saw bone, our readings may vary, but in a real scenario, when you do varus valgus stress, you will be able to find out what is happening to your gaps with the changes in the position of the knee. So if I get my knee into extension, right, from flexion, and into complete extension. So if I look at this position, my knee has got it's a little tight in on the medial side, whereas the 90-degree flex position, it's almost balanced. So if I make a little cut more on the medial side, this would be balanced, and it is also showing 5-degree varus in the extended position of the knee. So our robot has got us to this place that if with the settings that we have, the distal cut on the femur is 9 and the tibial cut on the healthier side is 9. So that's the natural cut that we always make. So when we look at the calibrations, what it's showing here is that in flexion, these medial and lateral spaces or the structure should be equal. The value should be closest to being equal, and so should be the position on the extension on the tibia. The value on the medial side of tibia is biased at this stage because of the tight posteromedial structures or the meniscus being there or the tight capsule being there. So this value is usually managed after you have made the cuts, and all the values should be closest to each other. But at this stage, if these three values are okay, we are okay with it. They can change it by distalizing or proximalizing our distal femoral cut, the posterior femoral cut, the rotations of the femoral component, the flexion and extension of the femoral component, or distalization or proximal placement of the tibial cut. So these are different combinations which we can do. So we will be talking about it in detail in different screens. So now let's go to the stage where we make the actual cuts. So now, since the planning has been done, so now according to what we have planned, the robot will go into the position where the cuts have to be made. You can see that it's rotating and going to the position to make the cuts. We have been talking about the precision of the robot. So if there is a minimal movement of the limb, right, the robot should automatically adjust so that it doesn't falter or make the incorrect cut. So we can see that as we move the thigh, the robot automatically makes the movement. So it moves to adjust with the movement of the limb of the patient. All right, so it's making the adjustments. So this is what is a robotic assisted total knee replacement. Now we are ready with the cuts that we have planned. So this is the first cut that we made. Alright, so this is the anterior femoral cut that has been made. Alright, so this is the cut that the robot has made according to the planning that we had done. At each step of the surgery, the surgeon needs to verify whatever is happening. So for example, at this step, we can verify and then see whatever is the variation from the original plan. So this is how a robot assists a total knee replacement. So what did we learn here? We learned there are 3 things that a robot does, and there are 3 things which a robot does not do. Robot will not expose, the robot will not close, the robot will never ever put the implants. So exposure is surgeon based, closure is surgeon based. When the cuts are being made into the femur and the tibia, the robot is going to help. But when the patella, right, the bone above it, that has to be cut, the surgeon has to do it himself. The cuts which are here, right, they are made for cruciate retaining knee. But if I am doing a cruciate sacrificing knee, then a robot will not help me cut the notch. Why not? Because that's the area where the blood vessels and the vital structures are. So that again goes to the hand of the surgeon. So a patient very commonly asks me, is it safe? So whatever are the important things, they are controlled by the surgeon. The important things are the tissues out, the tissues in, and the vessels here which go at the back of the knee. They are all in control of the surgeon, right? The placement of the implant is controlled absolutely by the cuts that we make. But then when we place it, remember that out of the 2 cuts, it is the tibial cut which is more important. So this is a tuned knee, and the femoral component we are placing on the femur. This sits very well along the margins of the lateral condyle. This is the tibial component, and we will place it on the tibia, reduce our knee, and then test for stability and the alignment which we wanted to achieve before making the cuts with the robot. And once we are happy with what we have done, right, we call it a day. This is about robot assisted total knee replacement. Thank you.
मेरी टांगे टेढ़ी हो जाएंगी, कुछ हो जाएगा, नहीं।
अब तो सीधी हो गई,
बिल्कुल सीधी हो गई।
पहले तो ऐसे गोल थी।
बिल्कुल 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 ये ऐसे थी, अब बिल्कुल सीधी हो गई।
मैं अपने घुटनों से बहुत परेशान थी। मेरा कहीं आना जाना बंद हो गया, जहाँ तक कि शादी वगैरह में भी नहीं जा पाते थे और कहीं भी घूमने के लिए नहीं जा पाते थे। मैंने कई डॉक्टर को दिखाया, मगर मेरे को उनसे सेटिस्फेक्शन नहीं हुआ। फिर मैंने डॉक्टर अपूर्व को दिखाया, इन्होंने मेरे को देखा और इन्होंने बोला कि आपके घुटने बदले जाएंगे। तो इन्होंने मेरे घुटने बदले। आज मेरे को अभी महीना ही हुआ है और मैं खुद चल के आई हूँ और मैं पूर्व साल का बहुत ज़्यादा धन्यवाद करती हूँ कि इन्होंने मेरा इतना अच्छा ऑपरेशन किया, जिसकी वजह से महीने से ही मैं अपने घर से बाहर तक पैदल चल के आई हूँ।
डॉक्टर अपूर्व, टन्स ऑफ थैंक्स। उन्होंने इनका नी रिप्लेसमेंट किया और आज 1 महीना हुआ है और ये बिल्कुल 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 ठीक है।